Lung cancer. Lung cancers are the fourth most common cancer reported in the Indian males. It accounts for 6.8% of all malignancies in India. Etiology. Cigarette smoking is the most important risk factor in the development of lung cancer. Smoking is responsible for approximately 80% to 90% of all lung cancers. Tobacco smoke contains 60 carcinogens in addition to substances that interfere with the normal cell development. Cigarette smoking, a lower airway irritant, causes a change in the bronchial epithelium, which usually returns to normal when smoking is discontinued. The risk of lung cancer is gradually lowered when smoking cesses and continues to decline with time. 10 years following cessation of smoking, lung cancer mortality risk is reduced 30% to 50%. The Memorial Sloan Kettering Cancer Center has developed a tool that calculates risk for developing lung cancer for older smokers and ex-smokers. The risk of developing lung cancer is directly related to total exposure to cigarette smoke, measured by total number of cigarettes smoked in a lifetime. Age of smoking onset, depth of inhalation, tar and nicotine content, and the usage of uninfiltrated cigarettes. Side stream smoke contain the same carcinogen found in mainstream smoke. This environmental tobacco smoke inhaled by non-smokers pose a 35% increased risk of the development of lung cancer in non-smokers. This exposure, called passive smoking, can occur early in life for children or smokers. Children are more vulnerable to environmental smoke than adults because their respiratory and immune systems are not fully developed. Childhood exposure to cigarette smoke is associated with the increased prevalence of asthma among adults. Children exposed to cigarette smokes are more likely to become smokers. Those who smoke pipes and cigars also have an increased risk of developing lung cancer. The risk is slightly higher than that of non-smokers. Cigarette smokers are at higher risk of lung cancer than are pipe smokers. However, heavy smoking of cigar and inhalation of smoke from small cigar correlate with the rate of lung cancer observed in cigarette smokers. Another major risk factors for lung cancer is inhaled carcinogens. These include asbestos, nickel, iron and iron oxide, uranium, polycycline, aromatic hydrocarbons, and air pollution. Exposure to these substances is common for employees of industries involved in mining, smelting, or chemical or petroleum manufacturing. The cigarette smoker who is also exposed to one or more of these chemicals or to high amount of air pollution is at significantly higher risk of lung cancer. There are marked variations in a person's propensity to develop lung cancer. Today, no genetic abnormality has conclusively been identified for lung cancer. It is known that the carcinogen in cigarette smoke directly damage DNA. One theory is that people have different genetic carcinogen metabolism pathways. Pathophysiology. The pathogenesis of primary lung cancer is not well understood. Lung cancer is thought to arise from bronchial epithelial cells. These cells grow slowly and it takes 8 to 10 years for a tumor to reach 1 centimeter in size, which is the smallest lesion detectable on an X-ray. Lung cancer occur primarily in the segmental bronchi or beyond and have a preference for the upper lobes of the lungs. Pathological changes in the bronchial system show non-specific inflammatory changes with hypersecretion of mucus, desquamation of cell, reactive hyperplasia of the basal cell, antimetaplasia of normal respiratory epithelium to stratified squamous cell. Pathological type of lung cancers are peripheral adenocarcinogens. Primary lung cancers are often categorized into two broad subtypes: non-small cell lung cancer and small cell lung cancer. Lung cancer metastasis primarily by direct extension and via the blood circulation and the lymph system. The common sites for metastatic growth are the liver, brain, bone, lymph node, and adrenal gland. Paraneoplastic syndrome. Certain lung cancer cause the paraneoplastic syndrome, which would result from the production of active substance, example hormone, enzymes, antigens, that are either by the tumor itself or in response to the tumor. Small cell lung cancers are most commonly associated with paraneoplastic syndrome. The systemic manifestations seen are hormonal, dermatological, neuromuscular, vascular, hematological, and connective tissue symptoms. These symptoms can respond temporarily to asymptomatic treatment, but they are impossible to control without successful treatment of underlying lung cancer. Clinical manifestations of lung cancer. Lung cancer is clinically silent for most individuals for the majority of its course. Asymptomatic patients whose cancer is found on routine chest X-ray account for about 10% of new cases. The clinical manifestations of lung cancers are usually non-specific and appear late in the disease process. Manifestations depend on the type of primary lung cancer, its locations, and metastatic spread. Persistent pneumonitis, that is a result of obstructed bronchi, may be one of the earliest manifestations, causing fever, chills, and cough. One of the most common symptoms, and often the one reported first, is a persistent cough that may be productive of sputum. Blood time sputum may be produced because of bleeding caused by malignancy, but hemoptysis is not a common symptom. Chest pain may be present and localized or unilateral, ranging from mild to severe. Dyspnea and an auscultatory wheeze may be present if there is bronchial obstruction. Later manifestation may include non-specific systemic symptoms such as anorexia, fatigue, weight loss, and nausea and vomiting. Hoarseness may be present as a result of involvement of the laryngeal nerve. Unilateral paralysis of the diaphragm, dysphagia, and superior vena cava obstruction may occur because of the intrathoracic spread of the malignancy. There may be palpable lymph node in the neck or axilla. Mediastinal involvement may lead to pericardial effusion, cardiac tamponade, and dysrhythmia. These are the main clinical manifestations of lung cancer. Diagnostic studies. Diagnostic tests of lung cancers are history and physical examination, chest X-ray, sputum for cytological study, bronchoscopy, CT scan, MRI, positron emission tomography study, spirometry, mediastinoscopy, video assisted thoracoscopy, pulmonary angiography, lung scan, fine needle aspiration. These are the main diagnostic measures of lung cancers. Staging of non-small cell lung cancer. Stage 1 characteristic, tumor is size and localized to lung. No lymph node involvement. Tumor size is below 3 cm. Stage 2 tumor size is greater than 3 cm with inversion of lymph node and same side of chest. Sometimes bronchus, lymph node, some other organs be affected. Stage 3 cancer, that means tumor spread to nearby structure, chest wall, pleura, pericardium. Stage 4 lung cancer, distant metastasis. What are the collaborative therapies of lung cancer? Surgery, radiation therapy, chemotherapy, bioanti-target therapy, prophylactic cranial radiation, bronchoscopic laser therapy, photodynamic therapy, cryotherapy, airway stenting. These are the collaborative therapies of lung cancer. Nursing management of lung cancer. Nursing assessment. It is important to determine the underlying of the patient and family concerning of diagnostic test, the diagnosis or prognosis or potential diagnosis, treatment options, and the prognosis. At the same time, the nurse can assess the level of anxiety experienced by the patient and the support provided and need by the patient's significant others. Subjective and objective data that should be obtained from a patient with lung cancer. Nursing diagnosis. Nursing diagnosis for the patients with lung cancers are: first one, ineffective airway clearance related to increased tracheobronchial secretion and presence of tumor. Second diagnosis is anxiety related to lack of knowledge of diagnosis or unknown prognosis and treatment. Acute pain related to pressure of tumor on surrounding structure and erosion of tissues. Last one, imbalanced nutrition. Imbalanced nutrition less than body requirement related to increased metabolic demands or increased secretion, weakness, and anorexia. Then another one of nursing diagnosis is ineffective health maintenance related to lack of knowledge about the disease process and therapeutic regimen. Ineffective breathing pattern related to decreased lung capacity. Planning. The overall goal and that the patient with lung cancer will have: first one, effective breathing pattern; second, adequate airway clearance; third one, adequate oxygenation of tissue; minimal to no pain, and realistic attitude towards treatment and prognosis. Nursing implementation. Health promotion. The best way to halt the epidemic of lung cancer is for people to stop smoking. Important nursing activity to assist in the progress toward the goal include promoting smoking cessation program and actively supporting education and policy changes related to smoking. Important changes have occurred as the result of the recognition that passive smoke is a health hazard. Laws require designation of non-smoking area or prohibiting smoking in most public places and a ban of smoking or airline flights. Other actions aimed at controlling tobacco use include restriction on tobacco advertising on television and warning label requirements for cigarette packing. For the individual who does not have a smoking habit, effort should be made to assist the smoker to stop smoking. The updated evidence based guidelines treating tobacco use and dependence. Clinical practice guidelines describe a framework for approaching the patient who are willing to attempt to quit smoking. The 5A stand for 5 strategies: ask, advise, assist, and arrange. The 4 stages of changes identified in smokers attempting to quit include contemplation, preparation, and action. Each stage requires specific action to progress to next stage. Nurse working with the patient and at their individual stage of change will help them progress to next stage. For patient unwilling to quit, motivational interviewing to recommended. The evidence-based guidelines also offer the 5 R's strategy for motivating smoker to quit. Risk, re- relevance, risk, reward. Acute intervention. Care of the patients with lung cancer will initially involve support and reassurance during the diagnostic evaluation. Another major responsibility of the nurse is to help the patient and family cope with the diagnosis of lung cancer. The patient may feel guilty about cigarette smoking having caused the cancer and need to discuss this feeling with someone who has a non judgment attitude. Counseling from a social worker, psychologist, or member of the clergy may be needed. Nursing research focusing on the effect of spirituality on the sense of well being of the people with lung cancer found that people with more meaning in their lives had decreased symptom distress. Additionally, prayer was associated positively with the psychological well being. This validates the impact of spiritual care from these patients and help guide nurses practice in spiritual need. Specific care of the patient will depend on the treatment plan. Providing symptom management is critical. The nurse needs to monitor for signs and symptoms of progressive or recurrent disease and notify the physician if this is suspected. Postoperative care for the patient having surgery is discussed later. Care of the patient undergoing radiation therapy and chemotherapy. The nurse has major role is providing patient comfort, teaching method to reduce pain, monitor for side effects or prescribing medication, assess smoking cessation readiness, helping assess resources to deal with the illness. The nurse coordinate care with the members of the interdisciplinary team and keep the patient and family informed. Ambulatory and home care. The patient who has had a surgical resection with the intent to cure should be followed up carefully for manifestation of metastasis. The patient and family should be told to contact the patient if symptoms such as hemoptysis, dysphagia, chest pain. Evaluation. The expected outcomes are that the patient with lung cancer will have adequate breathing pattern, minimal to no pain, realistic attitude about prognosis.